Of course, I mean, diffuseness of disease is a major determinant of outcome because it implies more extensive atherosclerosis. If we speak about PCI, the challenge comes because of diffuse disease is associated to a smaller luminal size. And a major important determinant of long-term outcome of stenting is to achieve the maximal possible luminal area. So the first challenge you have is that you have to understand the dimensions of the vessel that you're going to treat. You have to understand which segment, a specific segment of the diffusely diseased artery you have to treat to improve hemodynamics and also to ensure that you can choose the adequate stent for landing in this diseased vessel. One of the aspects of difficulty of stent selection is that, again, you have large differences in sizes when you have diffuse stenosis. So particularly when a bifurcation is involved, or more especially when the left main bifurcation is involved, the difficulty for this is that you may have huge differences between the lumen of the daughter vessel, for example the LAD, and the parent vessel, the left main. And that is extremely important again to understand, because unless you are able to optimize the stent size and to achieve the maximal possible lumen, you will have in the long term less chances of obtaining a long-term good result. Well, I mean, obviously, if you have long stenosis, that means that in many occasions, and you have also dramatic changes in vessel diameter, that means that in many occasions one stent will not fit the different sizes that you have over the vessel. So you will have to overlap your stents in order to have perhaps a 225 in the distal part and then something that can reach up to 4 millimeters, who knows, in the proximal part. You cannot do that with a single stent. Now, why is it important? Because we know that the stent overlap is one of the critical issues also in terms of long-term vessel outcome. It may favor, stent thrombosis unless you are able to expand properly this area, you can optimize it, and you can ensure that the two layers of metal are not contributing to impaired luminal dimension. Well, something that we know for a long time is that the longer the stent you have and the smaller the luminal area of this stent, the higher the chances of restenosis. So the main challenge we have here is that if you use visual assessment to choose the size of your stent, naturally you tend to use smaller stents, mainly because it is very difficult for you to understand which are the reference areas where you can land with your stent and obtain the maximal possible size. And also because you are concerned that treating these vessels that have a lot of atheroma, if you implant a larger stent, you may cause a big dissection or even vessel rupture. Well, we started again to say that one of the biggest challenges we have is that angiography is a very poor tool in depicting what happens in a vessel that is diffusely diseased. So it is extremely important to understand first what is the substrate of the plaque that you have there. Is a plaque that is soft, it's a plaque that has a lot of calcium, as it happens in many occasions. If there is calcium, what is the distribution of calcium? Second, what has happened in terms of remodeling of the vessel as part or over this complex process of atherogenesis? Has the vessel enlarged and you have compensatory vessel enlargement with a big vessel with a small lumen, or on the contrary, you have the vessel shrunk and what you have is actually a vessel that is very sort of difficult to manage because it's fragile. So IVUS will inform you on vessel dimensions, plaque characteristics, and also very important, I believe, also for the interventionalist, whether you have positive remodeling or whether you have negative vessel remodeling. Well, in diffuse disease, physiology is really important, much more perhaps than the average cardiologist can appreciate. The first challenge you have is that in the context of a vessel that is very difficult to assess visually, with physiology and particularly performing pressure pullbacks, you can identify specific locations in this diffuse vessel where the pressure drop occurs, takes place, where IFR or FFR change dramatically. And this, of course, will provide immediately an alternative to improve hemodynamics of this vessel if you are able to tackle these specific locations. In other cases, you may be cautious about performing PCI because you have determined that the pressure loss, FFR or IFR, is taking place gradually all over the vessel. These cases are much more difficult to handle with PCI because you cannot aim for making a full metal jacket in a vessel that has these characteristics. In this situation, actually, medical treatment can be a better option than going for PCI. One of the main objectives pre-PCI is, of course, to assess if you have to perform plaque preparation. In many occasions, actually, what happens is that the IVUS itself will tell you about the difficulty of getting around or getting through with an instrument. You will have a difficulty, and typically in that situation, the point more distal where you reach with IVUS, you will see a circumferential calcification. The second thing that you have, of course, apart of knowing if you need to perform plaque preparation, is that you will have a very accurate measurement of vessel dimensions, and this will facilitate your stent selection. And finally, it will inform you, of course, of the location specifically where these stent edges has to be performed, and also if subsequent actions like proximal stent optimization will be recommended before you try to do any other maneuver. Well, as we know, the most important aspects of optimization of the stent with IVUS is that you can achieve maximal luminal dimensions, you can ensure that there is adequate stent apposition, and you can also rule that there are no other, say, destructuration of the stent. Now, in diffuse disease, these things may happen quite frequently. First, because these vessels typically have calcified segments where the stents may be not properly expanded with normal pressure inflations. The second one is that as it's normal in a vessel that changes and involves long segments, you have large variations in luminal diameter, and therefore a size may not fit all the luminal dimensions, and you may have more areas with stent malapposition. So, in a way, what the role of IVUS in this particular post-PCI scenario would be to ensure that you have expanded and apposed properly your stent over a long segment of a stented artery. The great value of IVUS co-registration is that first, when we are planning the intervention, we can accurately determine where the landing zones are in the angiogram, so subsequently we can apply the decisions that we made based on intracoronary imaging. And the same applies also after intervention. We can ensure that the stent is properly expanded, posed, etc., and identify clearly those areas where that require subsequent treatment or an optimization with further balloon expansion or any other maneuver. Well, we can think about this workflow as a structured way of addressing the important questions that we interventionists should answer before embarking, you see, in what is the intervention itself. And those questions are, in the first place, what is the tissue, what is the pathological substrate that we have there? Is it calcific? Is it fibrous? It is soft plaque? It is extensive calcification that is a napkin ring calcification of the vessel that will imply plaque preparation, etc. Second question is, which segment of the vessel do you have to treat? And here you can take the concourse also of physiology, particularly pressure mapping with IFR or FFR, that will tell you exactly the segment that you have to treat in order to improve the hemodynamics of the vessel. And when you know that, you have to answer the question, if I'm going to place a stent here, which is the exact location where I have to land a stent in order to get the maximum stent size. Second question you will have to answer is, if I choose such a big stent, am I playing safe? Do I have positive remodeling, meaning a large vessel around it that will not break or rupture when I implant such a big stent, or on the contrary, do I have negative remodeling? And finally, you need to know also the information about the length of the stent. Well, obviously, in the post-PCI part of assessing an intervention in a diffuse vessel, you have to first of all ensure that you have achieved a safe result. That will imply assessing, for example, that you don't have distal or proximal dissections in the vessel caused by a stent implantation that may happen in these very diffuse vessels. It's important to remember that there are some features in IVUS like chroma flow that may help actually to distinguish between images you see that are innocent from situations where you have deep dissections that can be treacherous. The second thing you have to do, of course, is to ensure that you have optimal apposition and expansion of the stent, a critical aspect, because we said that typically you will have long segments of the stenosis stented. And the third one, of course, will be also to look and to check for areas of stent overlap where you want to achieve a perfect result with maximal expansion of the stent in this particular area. So at the end of the day, the post-PCI assessment will be very important to ensure safety, but also to, in the short term, but also to ensure that in the long term you have the highest chances possible of having a persistent, good result of stenting.
Innovation and you. Philips.